Your diabetic patient with renal insufficiency presents with abdominal pain. The imaging test of choice is CT with contrast. Do you proceed with the test? What are the risks to the patients? How might you protect the patient from the stress of a contrast load? You are listening to ReachMD, XM 157, the channel for medical professionals. I'm Dr. Lee Freedman, and welcome to the Clinicians Roundtable. My guest today is Dr. Michael Rudnick, Associate Professor of Medicine at the University of Pennsylvania School of Medicine in Philadelphia. Thank you so much for being with us, Dr. Rudnick.
Oh, it's a pleasure to be with you, Lee.
Well, this is a common problem in practice, and as an internist, it seems to be more common than ever. Is that a true perception?
Actually, yes, it is correct. My expectation is this problem will become even more common, and I'll tell you why. There are several things that are occurring concurrently that make this almost like the perfect storm in terms of ingredients. Mm-hmm. The first is that as our population is living longer and longer, the percent of our population who have chronic kidney disease will be greater. And looking at data from like NHANES, et cetera, show that a significant proportion of patients or people over the age of 65 have underlying chronic kidney disease, and that's important to know because chronic kidney disease is the single greatest risk factor for developing contrast-induced nephropathy. The second is that the use of iodinated radiologic studies like a CAT scan is growing dramatically. Roughly, there are, about some 25 to 30 million CAT scans that are done each year in the United States, that use iodinated contrast. There's also a very large number, but not anywhere as large as that, of cardiac catheterizations that are done. What that number is fairly fixed, and also peripheral arteriograms, that number is fairly fixed. But the number of CAT scans will improve. And so you're taking this elderly population who are developing an increased prevalence of chronic kidney disease, and you're going to be doing more and more radiologic studies of iodinated contrast. And the third part of it is that, unfortunately, diabetes is also an epidemic, and more people are being diagnosed with diabetes and being treated for that. And when that's combined with renal failure, their risk of developing contrast nephropathy is extremely high, and that accounts for my terminology of the perfect storm, so to speak.
And is there a creatinine level or a GFR that we should look at that we say, okay, now this person is at risk?
Well, that's another excellent question. The problem that we have is that it's been known for some time now that serum creatinine by and of itself may not demonstrate a person who has impaired renal function, especially in the elderly population. Mm-hmm. And what's become very popular now is the use of equations to estimate the glomerular filtration rate. This estimated GFR is now becoming widely used. In fact, in many places around the United States, if a person goes to have routine blood work and they take their serum creatinine, their age, and their gender and their race, they will be able to predict or equate, a estimated GFR. And they use 60 or greater as relatively normal, and less than 60 as abnormal. So it's not unusual to have people with creatinines of 1.1, 1.2, 1.3, depending on, what age they are and what gender and what race they are, to have estimated GFRs of below 60. So rather than say that there is a specific serum creatinine, because a serum creatinine, for example, of, let's say, 1.5, in someone who is 25 years old and 200 pounds of muscle versus 1.5 in an 80-year-old woman who weighs all 40 kilograms.
Totally different.
Totally different in terms of the implications on the GFR. I mean, the first patient might have an estimated GFR of 70 or 80 cc's per minute with that serum creatinine, and the second one probably has an estimated GFR of closer to 20 to 30 cc's. So what many places are doing for screening is they are calculating the estimated GFR, and they're taking precautions if it's depressed. Now, at what level of estimated GFR should you take a precaution for? Well, first of all, anybody who has an absolute level of serum creatinine, you should be taking precautions. That goes without saying. And the higher the serum creatinine, the greater the risk, so therefore the greater the number of precautions that you should take. Mm-hmm. But we've also just said that you can have a normal serum creatinine and have a low estimated GFR, so that even with patients with normal creatinine in the elderly, it's worthwhile doing this calculation. And I would say that if the estimated GFR is 50 or less, that you should identify that patient as at increased risk and take precautions. Just one other point is that the estimated GFR is a difficult calculation to do on your own, handheld computer. But there are multiple websites, and one of them is Nephron, Nephron.com, that you just go into, and they ask you, right on the first page of that, you just put in the 3 or 4 variables that I just gave you, and you'll get your answer of what the estimated GFR is, in 30 seconds.
Oh, that's good. That's terrific. So Nephron.com, and you plug in the variables and gives you the estimated GFR.
That's correct.
Very good. And is this something that I send in my patient, they have the outpatient study? When should I recheck their creatinine? How quickly does this develop and then resolve?
Well, ideally, I think that if you have patients who have a history of hypertension or diabetes, which are the 2 leading causes of renal failure in this country, or if you have patients who are, over the age of 60, and you want them to get a study in which they're going to be receiving intravenous contrast or intra-arterial contrast, you should go ahead, first of all, before the study, you should obtain a serum creatinine. And if it's abnormal or if the estimated GFR is low, you should make the radiology center aware of that. Certainly, across the United States, if you were going for a heart catheterization, a cardiac catheterization, you would have to have a serum creatinine before they ever gave you the dye. That's just standard of care. Mm-hmm. If you were going for an arteriogram, you would have to have a serum creatinine before they gave you the dye. It's standard of care. For the CT with the intravenous injection, although the risk may be somewhat less, there is much more variation on what is considered standard of care. But more and more people are beginning to require or desire to have this serum creatinine, this estimated GFR, before giving intravenous contrast. It's a much bigger logistic problem. I think that the referring physicians can do a terrific job, if they know well ahead of time that they're going to, when I say well ahead of time, a week or whatever, that their patient is going to get that, to arrange for them to get the serum creatinine before they get the study so they can be properly protected if necessary.
What is the time course with this? Do we see the deterioration in that first 24 hours? How does this develop and present?
Sure. Well, there are a number of definitions that people use to qualify as an episode of contrast-induced nephropathy. One of the definitions is a rise in the baseline serum creatinine of 0.5 or greater. Some people use a definition of even more sensitive definition of a rise in the serum creatinine of baseline serum creatinine of 25%. So that just gives you that even small changes in the serum creatinine afterwards qualify for this. Now, you could say, well, does that mean anything? Are these small changes important? And that's a good question to ask. But I will tell you, looking at observational studies of about, there's 5 or 7 of them, in every single one that's been done, and these are patients, who got their contrast injected in the hospital during a cardiac catheterization, for the most part. In every single case, they were able to show that for patients who developed a rise in creatinine the way we just defined it, there was a greater risk of in-hospital mortality and morbidity, as well as a greater risk of 1-year mortality. So then you say, well, is that a cause and effect? Did this rise in creatinine really cause this increase in mortality? And the studies don't prove that it's a cause and effect. They show the association, but certainly it may be that the patients who developed the rise in creatinine were just sicker people to begin with, and those are the ones, and it just they were more at risk for contrast nephropathy. So contrast nephropathy was really just a marker of their underlying illness rather than a cause of a particular problem itself. So that's one way of looking at it. But there are experimental models in animals in which you can create, acute kidney injury in the animal, and you can have distant injury produced in the heart and in the lungs as well as other areas. So it may be something that acute renal failure sends out signals that does contribute to morbidity and mortality. At the very least, what these rises in creatinine tell us is that these are high-risk people, and they need to be followed more carefully than somebody who didn't have a rise in creatinine.
Are there a number of patients each year who actually go into a more serious, long-lasting renal failure from a contrast load?
I don't think we have any statistics on the number of people who actually develop this problem. And then, as part of the definition, what do you consider to be clinically significant as opposed to just a rise in the serum creatinine? Fortunately, I can tell you that the studies are pretty consistent in that of the patients who develop this, only a extremely small percent, just 1% or less, or 2% or less, the patients at risk for the need to go on dialysis. And the numbers wouldn't be much more for someone who develops oliguria. So the vast majority of these patients don't require dialysis, and the vast majority of these patients remain non-oliguric. But we also have learned in recent years for contrast-nephropathy as well as other forms of acute kidney injury, where we used to think that patients would fully recover and return to their baseline serum creatinine after the event was over. It's becoming increasingly observed that there's a proportion of patients, not an insignificant proportion of patients, who show recovery but do not completely recover back to their previous level of renal function, and their creatinine, which may have been abnormal to start with, now remains even more abnormal. That's of concern to us.
Well, I want to thank Dr. Michael Rudnick, who has been discussing with us contrast nephropathy. This is Dr. Lee Freedman, your host of the Clinicians Roundtable. You've been listening to ReachMD XM157, the channel for medical professionals. Thank you for listening.